Hello everyone, welcome to my channel. My name is Dr. Somshekar Reddy KS. I am here to share valuable information on thyroid problems. Before we speak anything, we know our body contains so many organs like heart, brain, lungs. In addition to that, we have glands. We classify either exocrine glands or endocrine glands. Exocrine glands are lacrimal glands, sweat glands, salivary glands, and so many glands in and around gastrointestinal tract. In addition to that, we have specialized glands called endocrine glands. Why they are all called endocrine glands? They produce hormones. Nearly we produce more than 50 hormones which are directly released into the blood. That's why they are all called endocrine glands. In that, the most important glands are pituitary gland on the skull, on the base of the skull, connected to the brain, thyroid in front of the neck, in addition parathyroid gland, adrenals above the kidney, part of pancreas, ovaries in women, and testes in men. They produce hormones which are involved in so many functions: growth, energy, blood pressure, bone strength, reproduction, urine concentration. Like that, there are a lot of other functions also, metabolic functions. One gland can produce few hormones or many hormones. Many hormones come together, work for some purpose. I already mentioned. Now my subject is on thyroid. Before we speak on thyroid, we should know what is energy. Metabolism. How thyroid is linked to energy? See, there are 10 hormones. More than 10 hormones are working for energy. I take 3 meals. My body requires continuous energy. First I have to store the energy. Then required amount should be released, and it has to be utilized for the energy generation. Insulin is the one which is produced from beta cells of pancreas, which helps to store the energy, mainly glucose. Once energy is stored, glucose is stored, then required amount will be released with the help of releasing hormones. They are all called counter-regulatory hormones against insulin, or stress hormones helps to release the energy. Once food is out or energy is out, again insulin pushes inside the cells. Once glucose has gone inside the cells, because our body is full of cells, all the cells require energy. Once glucose combines with oxygen, we get it through the air, energy will be produced with the generation of heat. This energy generation doesn't happen without thyroid hormones, that is T3, T4. So, thyroid is involved with energy generation. Insulin is to store the energy. And I have already covered how these stress hormones are important with respect to diabetes mellitus. That is there in my diabetes video. So, when we come to thyroid, for everybody, most of the endocrine glands in our body is under the control of pituitary gland. For thyroid, it produces thyroid stimulating hormone. In short, that is called TSH. Once TSH is produced, it will go to the thyroid. It stimulates, one enzyme will be there, that is called peroxidase. Once it gets stimulated, there will be raw materials will be there, including 4-iodine and 2 amino acids. Peroxidase stimulates to produce T4. Then once T4 is produced, it will be released into the blood. It loses 1 iodine, it will become active form, that is T3. So T3 is active, more active than the T4 for energy generation. So it stimulates in all the cells for energy generation. This is the thing. Say thyroid gland, we can compare it to the factory. Take any factory, we manufacture any vehicles. We will not release all the vehicles on the same day. We will keep the reserve. and we keep releasing only few percent. Remaining it will stay in the thyroid only. Once thyroid releases T3, T4, 99% always with the proteins in the blood. Less than 1% it will become free, that is called free. The thyroid hormones stays with the protein, that is called bound form. So bound plus free equal to total T3, what we do regularly whenever we do the thyroid function test. This is the normal physiology. So whenever we speak on any thyroid problems, it can be because of anything, maybe because of genetic problems or iodine related issues, iodine deficiency, or acquired forms or malignancies. But most of the problems we are getting autoimmune problems. Before we speak on any problem, we classify. Is it like anatomical or functional? So, or structural or anatomical. See, what I am is the structure, what I do is the function. Like that, any enlargement of thyroid is a structural problem, can coexist with the function problems also. So, any enlargement is called goiter. I may be defective structurally, I may do more work or less work or normal work, like that. So, enlarged gland can be overproducing or underproducing, that is a different issue. So, now we are getting more and more functional problem. That is called autoimmune problems, either hypothyroidism or hyperthyroidism. We will speak on goiter later. In this case, the most common causes or problems we are facing nowadays is the defect in immunity. What is this? We know in our blood we have three different types of cells: red blood cells, white blood cells, and platelets. Red blood cells to supply the oxygen because it contains hemoglobin. Platelets controls the bleeding. White blood cells protect against infections. So by producing antibodies or directly attacking the bacteria, viruses, or parasites. What is autoimmunity? In a genetically prone people, if the thyroid structure is modified with the interaction of environmental factors, structure of thyroid is changed. For white blood cells, it looks like a foreigner. By producing destroying antibodies, more destroying antibodies, they develop low thyroid. If they produce more stimulating antibodies, they produce high thyroid features. So that is called autoimmune, attacking our own organs or tissues without fit, proper cause. That is called autoimmunity. So that's why we do test called anti-TPO antibodies. I will speak later. So once they develop low thyroid, metabolism will become slow. Means, say you take one vehicle. If petrol doesn't burn properly, vehicle doesn't move, or it moves slowly. Or if vehicle becomes too much petrol is consuming, so engine will become very hot, like that. In low thyroid, they will have manifestations. So whatever the glucose or whatever the food we have taken, it will not be utilized properly. So they will have weight gain, sleepy, lazy, less hungry. Even if they don't take food also, they may not lose the weight, and some menstrual issues or some growth issues they may have, like that. In high thyroid, they will become, all organs will become stimulated. So weight loss, increased hunger, whatever they take, they will not gain the weight. So then sweating, tremors, palpitation, anxiety, irritability, decreased sleep, hyperstimulated, that is hyperthyroidism. So once they come, we do test called functions. We'll do function means blood tests, structure means ultrasound. Usually we don't do any scans, ultrasound in thyroid issues unless we suspect some other issues. If we'll do T3, T4, TSH, in low thyroid, T3, T4 will be less. As the T3, T4 started declining, TSH will be elevated. So Once thyroid is producing T3, T4, T3, T4 will be more, TSH will be less, overproduction or hyperthyroidism. In addition to that, we do test called anti-TPO antibodies. Anti-TPO. TPO is the one which stimulates thyroid to produce T3, T4. Once that antibodies are more, it goes in favor of autoimmunity. Usually we get anti-TPO antibodies. Even in the presence of autoimmune problem, antibodies can be positive up to 80%. It can be negative in 20% also. Positive higher titer will be in favor of autoimmune thyroid problem. Negativity will not rule out autoimmune problem. And if we suspect high thyroid, we'll do test called special test, that is technetium thyroid scan or radioiodine uptake study. That is sometimes to differentiate, see, for example, if the autoimmunity is, see, either hyperthyroidism or is because of overproduction of thyroid. Sometimes it behaves like hyperthyroidism, not exactly hyperthyroid, because of over release. To differentiate, we do test called technetium thyroid scan. If thyroid gland is producing too much and releasing, then whatever we have given the dye, it will take up and it will look very dense. That is called special technetium thyroid scan. With this, we will confirm. If low thyroid, we start with the T4 replacement. So it has to be given in there are a lot of companies with the different brands. We will start with the T4. It should be taken on empty stomach, means minimum 1 hour should be the gap. Why we take on empty stomach? It is a better absorption. It is not before meals, empty stomach. More the gap, better the absorption. More than 1 hour, better absorption. So we will be giving T4. Because if we take an empty stomach, absorption will be 50 to 70%. Once we give T4, it will be converted T3. As the T3, T4 started improving in low thyroid, TSH will start declining. Depending on the value, we will be adjusting. If T3, T4 is normal, TSH is normal, continue the same dose. If T3, T4 is less, TSH is more, increase the dose, not reduce the dose. If T3, T4 is more, TSH is becoming less, you have to reduce the dose. Sometimes, if TSH is not very high, we have started with the minimum dose, maximum dose 100 to 150, and we have given 50. Now T3, T4 may be normal, TSH may be normal. It means you are giving correct dose. After 6 months or 3 months, T3, T4 may become less and TSH may become increased. Probably thyroid was producing, further decline has happened with the production, so the requirement is increased. It doesn't mean that drug lost the effect. That's why we have to. Then where all the people they require more doses, more than 150 and all. Sometimes they have some problem with the absorption or the drugs which inactivates the thyroid hormones or something like more of the body weight, more of the requirement, like that. Then many people they come with the pregnancy, especially low thyroid people. So they will have so much problems, thinking that they will have so many problems. So in pregnancy, there may be some problems. Without thyroid problems, pregnancy related problems may be 1 to 5%. In the thyroid problems may be 5 to 7%. So what they may not conceive or abortion rates or some organ development, but 95% nothing will happen. Only few people. That's why we have to do the test and we will replace. In low thyroid we will be replacing. Then after replacing, weight gain is not because of thyroid. So people will think that I am hypothyroid, that's why I have thyroid problem, that's weight gain. No. When the report is normal, it's the intake may be more than that. In high thyroid, once we suspect, what we do is special scan. So that is called technetium scan. We'll confirm. Then later, after that, we have 3 options. One is surgery, second is radioiodine and tablets. Surgery, earlier we used to do for hyperthyroidism because of so many issues, because parathyroid gland will be there, it maintains the calcium, so chances of removing that gland are surgical related issues. Usually we don't do any surgeries in hyperthyroidism. Next is tablets. Tablets is good, it suppresses the production. So thing is, patient requires regular checkup and cost of that this thing, and different doses and different times. That's why after some time we'll make them to use like near normal. Then we'll plan for radioiodine. Radioiodine means radiation will attach to the iodine, then we'll give, and it will go and sit in the thyroid, and slowly it will destroy the thyroid. Then they develop low thyroid. Treating low thyroid is easier than high thyroid. So one dose may be sufficient for 80 to 90% population thyroid patients, or a few patients may require two doses also. Then that's radioiodine usually we don't give anybody is pregnant or nursing the baby or the planning pregnancy in very early. That's why once they give radioiodine therapy, they should not plan for pregnancy at least 6 months to 1 year. Then they should not be giving breastfeeding should not be there. Like that we start and we'll plan, and after giving radioiodine will be follow up. Giving T4 is easier than treating high thyroid. With this is a functional problem, and goiter, enlargement of thyroid is common with high thyroid, and low thyroid usually it is a destructive process. Initially may get slight enlargement, it will regresses. You don't have to worry. And even if thyroid hormones are normal, TSH is normal, some people may come with the enlargement. So it is some genetic problems. There may be deposition of some colloid thick material, they may be enlarged. So anybody with the normal function enlargement, it may be slight variation in the this thing, deposition of this thing, or some people 5%, less than 5% may harbor some malignancy or cancer. So that's why we may do FNAC. It may not be conclusive in all the patients, because the chances of malignancy slightly more with the normal function. Even if somebody who has got malignancy or cancer, 90% of the thyroid cancers are curable. So you don't have to worry. So the issues with thyroid, either we have to we may come across low thyroid, high thyroid that requires the treatment. Then enlargement maybe because of very rarely malignancy, it is curable. That's why we don't have to worry about thyroid problems.